interesting sounding session, and it is the mobile revolution, remote care, and adherence/acceptability data collection without compromising security and quality. And I'm going to let them introduce themselves, but with us today are Dr. Deborah Lafke and Stan Mirzwa. And if you guys would introduce yourselves and your interest in this subject and your organizations. Deborah?
Thanks, Jeff. Can everybody hear okay? Some? Okay. Well, I'm Deborah Lafke. I am currently with the University of South Alabama College of Medicine, and my role there is strategic health innovation well, we have a number of activities that we are doing in that area, including being the Alabama Regional Extension Center under the ONC grant. And as part of that, we also do telehealth with some of our rural providers, and that's why I'm here to talk about this particular subject today from a telehealth perspective, and also in a rural healthcare perspective.
Stan?
So good morning, everybody. My name is Stan Mirzwa. I come from an organization called the Population Council, headquartered in New York. So I'm the director of IT, and that means your typical director of IT stuff. I have to worry about the infrastructure and automation to help people do their day jobs. But another piece of my role, and an increasing piece, I think, for IT groups, is getting involved in what we call programmatic research. So aiding the scientists, the researchers, the doctors in being innovative and introducing technology into their projects. Most of the work that I get involved in this area in mHealth happens in the developing world, not here domestically. And so that makes it even more challenging. So I've been hearing a lot today and even yesterday about some of the challenges in the developed world. But I think a lot of that also applies to the developing area, and then perhaps with some more complexities. But I'm happy to be here, and I thank the Health Tech Council for giving me an opportunity to speak. And I'm actually having a hard time hearing. I mentioned this yesterday to several people. My ears are still clogged from the flight, so if I'm screaming, I ask Jeff to tap me on the shoulder.
And do you mind just giving a minute on the Population Council? Because I wasn't familiar with that organization.
Yeah. So the Population Council, and we're not population control, because I get that quite often. All right, that's not what we are. We focus in 3 areas: HIV and AIDS prevention, reproductive health, poverty, gender, and youth issues. So we have demographers, social scientists. We're not a university, we're not a hospital, but we do have biomedical labs where we have staff, over 100 staff, who are working and researching on coming up with HIV prevention products, but also contraceptives.
Thank you. So Deborah, let's get started with some questions, and then periodically, if you have a question, don't be shy. I'll try to ask periodically, but raise your hand if you'd like to jump in. Deborah, how does remote care complicate data security for healthcare providers?
So as I mentioned, one of the initiatives that we do at CSHI is telehealth. And just to put some context around that, this is in the state of Alabama. Alabama is a fairly large state geographically with a very small population. Population of the entire state would fit inside half of LA. So people are very widely dispersed. It's very rural, very agricultural, and there are few cities of any size. The largest city has just over 1 million people, and the next largest city has under 500,000. So what we're dealing with is a very widely dispersed population geographically. Complicating that further is that the poverty level in the state is extremely high. It's historically been a high poverty state. There are structural reasons for that, but the rural population is poor and very far from care. And so one strategy that we're using in the state is to try to increase the provision of telehealth to people in these remote areas. Some of the issues, though, that we have that complicate security are, one is the heterogeneity of the equipment itself. So we have to use what's available basically on site to try to provide telehealth care to people. And in our case, we're doing a lot of work with diabetics, people who have other chronic diseases, congestive heart failure, hypertension, who need monitoring on a periodic basis. But the complications that we face in terms of security are we don't necessarily know that we're going to have access to broadband. We don't know who's going to provision that. We don't necessarily know that we're going to be able to rely on cell phone service. So the way it complicates it for us as a provider, and we are the telehealth provider in the situation, is that we have to basically dumb it down, if you will. The telehealth that we're able to provide is really very basic, and it relies on landline telephones. People making calls back and forth to, for example, an interactive voice response system, upon which it's very hard to build a layer of security and basic HIPAA compliance. So that is one aspect of how care in remote areas is complicated by security, or complicated for security, because you can't use more advanced tools to secure the system when the system itself won't accept them.
Right.
I think you face some similar issues in less developed countries.
Yeah. We do, and in fact, I'll tell you a story. We built a system to collect data in Zimbabwe. Actually, it was in several countries, but I had this experience in Zimbabwe. So we were interfacing with the 3 clinics, and we were going to do electronic data capture around adherence, and we assumed internet connectivity was available. Okay, so we get out to the first clinic in Harare, only to realize that it was available, but about 10 miles away. So, you know, you have to be careful about, and I'm sure some of you may have stories like this and other like projects, but I think the idea being you can't always assume the resources will be available. But we also have to be concerned about, you know, the resources and, you know, where you can locking things down as much as possible, because you need to prevent, especially if you're going into areas, and I think as Deborah said, you know, where there's constraints around resources, you need to keep it as simple as possible for the people who will be using the products.
Thank you, Stan. Deborah, we're going to continue down the same road for a little bit longer here. So what are some specific areas where additional security needs to be put in place, needs to be implemented when functioning as the healthcare provider doing that remote care?
Well, additional security needs are again, context dependent. So it depends on how you have a system set up. In our case, we have brought it all in-house. So we can control the security, all the security around the system, this particular telehealth system that we're using. But what hadn't been done up until recently was a complete risk assessment of how the system was set up. And so we had, we found ourselves in a situation where we had all of the security controls that you would want to have on a server, set up with good access controls and located in a secure facility. But we found that we had individual users who were bringing up patient records on their screen, and they did not have locking screensavers. They didn't have a timeout period. In fact, they couldn't even lock their doors to their offices should they need to. And so it's not so much a question of additional security when you're doing remote care. It's not different security. Where it's located is important, but it's also important to make sure that you do a complete risk assessment that takes the remote aspect of it into account. One of the interesting quirks that we had with the system also was the actual presence of the equipment in the person's home. We provide them with things that they can't afford, like a talking scale, if we're monitoring them for congestive heart failure, and with an actual telephone if they don't have one, which many of these people do not. But what we found was that there was a high incidence of theft of the equipment by other members of the family who saw a need to turn it in and get some money. So, you have to think through what the possible scenario is going to be out in the field. If you're going to provide them with equipment, you have to be prepared to replace it when it gets stolen, which it almost inevitably will. Those are sort of some nuts and bolts security issues that you have to take care of.
Sure. Stan, so over on the broad subject of adherence and acceptability, when it comes to adherence and acceptability data collection in clinical trials in the developing world, why is the use of innovative technology important or even considered?
So a couple things come to mind. Number one, when it comes to, just because we're doing these studies in Africa or in areas where resources are not what they would be, let's say, here domestically, it doesn't mean they don't want to be efficient, okay? And there's a technology we've implemented. Actually, we built some software, goodness, about 10 years ago, and I like to say a high school student could have written this. It's called the ACASI, Audio Computer Assisted Self-Interviewing. It's used in trials when you want to try to get better responses to questionnaires. So the example is this. We give the participants, it could be a smartphone, it could be a tablet computer with headphones. They put it on and they listen to the questions in their local language, and it's recorded locally from their village, because there could be different, certainly different languages, many languages. We've been involved in some studies where we've had 14 languages for one questionnaire. So you get a consistency, number one, in the way the interview is taken. But on top of that, you also, some of these questions are very sensitive. As I said, we do a lot of work in HIV prevention. So if I was to ask Jeff a question such as, and I'm probably going to regret I say this, but Jeff, with how many partners have you had sex in the past 30 days? Okay? So I ask him right here, I'm looking at him, right, exactly.
Let me call my wife and ask her.
Right, okay, so now person to person, face to face, they call that, he might be less willing to be honest. So studies have shown, research has indicated that the way you interview certainly affects answers to sensitive behaviors and sensitive questions. So what we'll do is we'll give the device to the participant. They'll go to a room by themselves after going through some training. They'll listen to the questionnaire. They'll respond. In many cases, they're illiterate or semi-literate. They cannot read. We put the text on. This is an argument I have all the time with the scientists. Why are we putting the translated text on these devices? Because they're listening to the questions, but it's there nonetheless. They respond by looking at color-coded boxes, pictures, numbers. So the idea being we'll get better responses. And our goal, I'm a technology person, I'm not a scientist and I'm not a doctor, but our goal in our group is to help get the best data we can. So there's a couple things. There's the efficiency factor. Some of these trials involve 3,000 or 4,000 participants times 7 questionnaires. It takes manpower to have a person, or people power, I should say, to perform these questionnaires. So if you can automate with technology, it makes sense. So that's one way that we found technology useful. And there's certainly, again, back to the point, we want to follow good practice, but we also want to introduce technology in these areas. I'll tell you, in one case, we do a lot of pre-testing of surveys when we go out to these clinics, and in some cases, many of these participants in this particular study were women. This was the first time they were seeing technology or computers or tablets. And I think they felt empowered by that. And I remember one debriefing after doing a pretest where a woman came up and said, I felt important because I was using technology, so thank you for that.
So, as an interesting counterpoint to that, of course, we're putting similar types of technology out into the field with our rural impoverished diabetics, and what we find is, in many cases, a rejection of more advanced technology. For example, we did a trial to try to, instead of using the interactive voice response system, to try to use text messaging to provide supportive messages to our patients. And we could not get people to enroll because they thought that if we gave them a smartphone, we were giving them a phone card to use for the purposes of this study, cost them nothing. And they were very suspicious of our motives. We basically, I think, probably took a position of more paternalistic than we should have, and we put this in the hands of some of the nurses to try to recruit patients. And we actually had people tell the nurses that they didn't want the phone because they didn't want the government monitoring their business. So in the end, enrollment just basically killed that study. We were trying to enroll 200 people, and only 17 signed up. And of those 17, only about 10 of them actually responded and had a dialogue with the text messages. So you really, it's important when you're thinking about revolutionary mobile technology and how it can empower people, it's important to think about the context and really understand the dynamics of your population and develop an approach that is going to make them feel empowered and not spied upon.
Right. Well, thank you, Deborah. Stan, I want to hit you one more time here. Did you actually go mobile in your design system solution to help capture this adherence acceptability data? And what are the biggest hurdles or challenges to going mobile in this context? And on the flip side, what key success factors are there that make mobile potentially a timely choice?
So, before I answer, I just want to mention something on top of what Deborah just mentioned about the context and local use. And this is an interesting story. This was going back about 10 years when we introduced ACASI in Kenya, and the idea that participants were afraid of the computer. This was a household-based survey, and we were going through villages outside of, this is several provinces in Kenya, and there was talk through the community that these computers with these headsets on were sucking the blood out of the people. So beware of these computers. Now, we've gotten past that, but things you may not expect when you're designing these. So I'm not embarrassed to say a lot of what we do with data collection, we keep off the grid. When it comes to the systems we provide to the participants in these clinics, we can't be guaranteed we'll have connectivity. And so we haven't gone mobile in the regard of the devices. We consider this a kiosk piece of equipment. We provide it, we set it up, we know what's on the device, it's locked down, it only runs one thing, and these are the questionnaires. Now, that said, the data has to merge at some point to a source computer and then be uploaded or made available to the scientists. That part we do make available and connected. We get sometimes hit pretty hard and criticized about that. And the investigators will say, look, why can't you just make this completely mobile available, let people use their own? Smartphones and phones are available everywhere. Come on, just go for it already. But there's a lot of issues, and the security is one of them. So we actually did not In fact, right now, we're working on a system that will be connected. It'll be piloted here in the US. Again, it's questionnaires, but interestingly, we're looking at, because it's a different population here domestically, gaming. You know, some of you might be familiar, you know, with the Wii or your Xbox, the use of avatars, using avatars to do a questionnaire. That will be connected. It's a system being built with HTML5. In any case, so I think it depends on the environment. In our case, when it comes to, you know, this is clinical trial data, we're very conservative about that. So we did not
Yeah.
go mobile.
Deborah, if it's okay, I'm going to swing back around you. We were talking about mobile devices and security. How can data and mobile device security be effectively monitored? I mean, the whole issue of ongoing monitoring and compliance.
So this is a burning issue for many people, is the security of the mobile devices that are out in the field. It's particularly, as I mentioned, it's particularly relevant to our widely dispersed population. You can't have somebody there monitoring what's happening with that device, and it's difficult to know actually who has control of the device, and it depends on how you set up the system. So what you want to do in order to monitor the data is make sure that it doesn't live on a device that is in the wild, so that can't be effectively monitored. You have to move the monitoring from the device up the food chain to where the data is ultimately going to live in order to effectively monitor access to it. So in our case, the IBR system the IBR system captures data from the patient's phone, but the data is not stored on there because they're using basic landline. So in the way the system is configured, we avoid the question of monitoring patient's use of the device and move it up to a place where we can monitor it. But if you are going to go mobile and use smartphones instead of landlines for what we're doing, we'll have the same situation that Stan encountered, which is having to lock down the device at the point where it's used. And basically, you said it's kind of a store and forward configuration. It's one thing that we know we don't want to do is put the security in the hands of the patient. Right. And burden them with that responsibility while they're receiving telehealth care. So we want to eliminate situations where we're monitoring their behavior as far as security is concerned. That gets in the way of actually providing the care and reduces the trust between the provider and patient.
Well, it goes hand in hand with the previous question, but who is responsible for monitoring the security and the compliance on those devices in your scenario? The institution?
The institution is responsible. We have, well, the way the program is set up in our state, we have a distributed set of managed care organizations that contract with state Medicaid. These are all Medicaid patients that I'm talking about. So we have BAAs with those contractors, and they are ultimately responsible for their patient data. We collect and store it on a secure system that has been audited for compliance.
Right. So, Stan, back to adherence and acceptability, and two of these kind of go together. Some of the studies you've been involved with, what were some of the more important lessons learned, and was the juice worth the squeeze? Did the researchers and donors think that technology was worth the investment?
Yeah, so a couple pieces of interesting information, right? We, and these are mostly stories, but I think they're helpful. One is we had built a system to collect data to be used in Pune, India. And it was electronic data capture system. Again, it was around acceptability. It was a placebo project around a ring, a vaginal ring. And we had put numbers on the screen. So to many of the responses of the questions, the participant had to click on a number with their finger or stylus. Well, we learned that once we went to the site, and we had done this also, in this study, it was in 3 sites, one in Alabama, one in New York, and one in India. We learned that 30% of the population could not read Hindu-Arabic numbers. Well, that was a big problem for us, right? Because we had developed a system, and then we realized, goodness, they're not able to respond to the questions. So we had to turn around and change it and use pictures. So an important lesson we learned is when we go to some of these countries, you should look at the literacy maps. Another is color. I mentioned color-coded buttons for responding, again, for this population that cannot read. Well, we had blue and green and a couple other colors on the screen. Well, blue and green is used interchangeably in South Africa. You can't put those 2 on the screen. So another valuable lesson learned. Another, going back to the intimate or sensitive type of questions, we had a picture. I see some people smiling and laughing, and these are just real examples. A picture about, sexual relations, and the bodies were not covered, and this was also in India. Well, guess what? Going to the sites and pre-testing, we were told cover the bodies with a blanket, but not just a blanket, a specific color blanket. So these are all very, you may be thinking, goodness, these are just details, but they're important because we want the participants to be able to accept the system, and that's an important thing. So I think those are some important lessons. What that means is customizing a system, and it goes to your point, Jeff, about cost. When you build something custom, we would love to have a system that everybody uses, Excel, for example. Here's Excel, go to town, use it. You have it, it's one system, it could be used any way you want it, but we are really in the business of customizing for the scientists, and in this case, that costs money. So we are often asked, and more recently, because we've been doing this about almost 10 years now, when you start to get questions, how much does it cost to do a survey per participant? They're starting to think about the costs, and is it worth it? And I think those are things that they haven't said stop doing this, because there's still value in obtaining good data. But the question certainly comes up about cost.
Thank you. Deborah, how can these disparities in care be avoided in situations where this transformative mobile technology is less accessible to patients because they're rural, poor, low educational attainment, low literacy, et cetera? How can those disparities be avoided?
So I don't know if I have an answer to the question of how they can be avoided, but I think it's very important that as we go forward with the adoption of mobile technology for telehealth and other healthcare uses, that we are mindful of the fact that we can create disparities between the technologically adept urbanites and people who are not exposed to this technology. I distinctly remember sitting around tables in Washington, D.C. in my previous life at ONC with a lot of people who made a lot of assumptions about people's access to advanced technology across America. And they made assumptions that were very indicative that these people had never been outside the Beltway. They had no idea what it might be like to live in a small town in a rural state, where you may not have a cell tower for miles. You may be nowhere near an interstate, and I think that there are a lot of assumptions made about the role that mobile technology can play that are based on people's access to technology that is not accessible to everyone. And so as we go forward, if we want to avoid these disparities in care, we need to, first of all, be mindful of them, And second of all, come up with some plan for mitigating those, which what I have seen done up to this point is basically giving them the technology. But there's more to it than that. You can't make a person technologically adept just by handing them a smartphone. So there's training involved. Many of these people are functionally illiterate, if not illiterate outright, or they may have a language barrier. We have fishing villages in Alabama where English is not the first language of anybody and not widely spoken. And yet these people are living in poverty, and they are reliant on FQHCs for their health care. So when we're in the process in Alabama of building out the Alabama Partnership for Telehealth, which is bringing together all of the stakeholders in the state, the telecoms people, the state itself, everyone who's providing telehealth in the state, to try to take a comprehensive approach to putting mobile technology and telehealth care into the hands of these underserved populations. But context is important, training is important. We need to reach people where they are and realize that there's a much heavier lift to get them to the point where urbanites are.
Any questions at this point? We're going to have time at the end, but if anybody has a specific question, feel free to raise your hand, and we're going to keep going, and we'll swing back here at the end. So this, for really either one of you, Stan, certainly you can start this, but what, as it relates to security and quality, what special sort of design considerations have you taken to ensure that the data collected remains secure, remains unaltered, et cetera?
So in our case, as I mentioned earlier, data is captured off the grid, merged with a data management computer, and then is typically sent to an organization that will analyze the data and do the quality control checks so that they can communicate back to the sites or clinics. I learned a lesson with this. Don't get, we like to develop the system, but we don't want to look at the data. That is not our role. We shouldn't even look at the data as technology folks. So relying on organizations. One, we work with, they're called SHARP, the Statistical Center for HIV and AIDS Research Program. They're based out in Seattle. Well, they collect the data. They take the data and then they put it through their quality control checks. Now, it doesn't mean we wipe our hands and we say that's it, we're not involved, because we still need to be involved if there's a problem. But that's a way of keeping some sort of checks and balances. You don't want the tech folks, I think, messing with the data. If there's errors, let it be reported and be corrected. But again, I like when it's another organization that does that. So that's one thing we've done. I heard this, Deborah mention this about locking down the devices. I brought this up in an earlier session. We provide the devices, but they're locked down. They could only do one thing. It seems like a waste of technology at first, because you're saying, goodness, you could do so much with this. But at the same time, when you open it up, you're going to have more problems. I don't want to be in the business of, maintaining a 100-person help desk, for example, to correct issues that come about because you've opened up the device a bit more. So it seems a bit controlling, but at the same time, I think it does eliminate the basics. The basics, something getting installed, something, any tampering with the device, any infections, that sort of thing.
Deborah, as it relates to telehealth, again, greater burden on the patient can translate to lower adherence to a treatment plan. How can that problem be avoided or minimized?
So the objective is to, in using telehealth and the way that we've deployed it, the objective is to put no more burden on the patient to adhere to their treatment plan than they otherwise would have. So we want to make it easy for them to comply. What we do is, in our particular system, we do monitor their adherence. So as I mentioned, it's an interactive voice response system, you know, really basic. They call in their glucose readings once or twice a day, depending on what their doctor has ordered. The doctor in the background has set threshold values. So if those threshold values are exceeded, that triggers an automated message to the care coordination nurse, who then will call the patient on the phone, find out what's going on, and help them to control their glucose readings, counsel them on their nutrition or their medication, and so forth. This chain of events, we found, makes the patient feel like they're being cared for in the way that they would be cared for if they were actually going to the doctor's office. And it relieves them of the burden of transportation. So it actually increases adherence to the treatment plan. Instead of having to drive 40 or 50 miles to see a doctor, these rural patients are cared for where they are. And we've had very good results with this. We've had not as good results in requiring people to drive to a clinic to be seen on a monthly basis, which is basically what they're able to do. Instead, we can monitor it every day. It helps to, in diabetes in particular, it helps to avoid situations that can lead to a worsening, an irreversible worsening of their condition, where, you know, when glucose is not controlled in the bloodstream, it can lead to damage that can't be undone. And so as we're able to continuously monitor them, they feel better, they adhere better, and it sets up a virtuous cycle.
Okay. So, Stan, one more for you. Going forward, now that you've helped to provide some technology solutions to help collect this adherence and acceptability data in the developing world, what do you see on the horizon or is currently happening to really help drive and improve these efforts?
So the whole idea of mHealth is exploding, right? There's a lot of hype around mHealth, and this is a form, certainly, of mHealth, the data collection I've been involved in. A couple things that I see happening, and some of you might be familiar with this. I've often been asked, okay, this is good, you're collecting behavioral data, you're getting, you're finding out whether participants are, willing to use the drug or the regimen, whatever it is we're studying. They accept it, or you're finding out why they're not using it, perhaps. But really, what it comes down to, are they actually using it? And so what I'm starting to see are products such as, there's a product from Excel, it's called the Smart, and what that does, and some of you might be familiar with it already, they add some sort of, it's called a taggant to the medication, and what will happen is there's a small device that you breathe into to tell you whether they've actually taken the medication, and then it automatically texts the messages back to a server. So you're starting to get a little bit better knowledge about whether they're adhering to the medication. So there's this sort of, very sophisticated model that's starting to come around. Another one that I was involved in a study, something called the Wise Bag. Some of you might be familiar with this. It's a bag. It's also called a Wise Pill. If there's medication that will be used in a trial. And again, I'm the IT person, but I've gotten into this area because a lot of these trials include technology. The idea is there's a bag that has the medication. You open the bag. It opens up. It sends a message directly to a server. Again, you can tell whether they're making the attempt to take the medication. Not whether they took it, but whether they made the attempt. And then full cycle, if they didn't open it, well, they're getting a call or a text, or somebody's trying to contact them about whether they've, why they haven't taken their medication. I think going back to the hype, this whole area of mHealth will continue. And I'm reading a book called mHealth in Practice, and they made a really good sort of connection with what's currently going on. And I haven't, some of you probably can Google this, but I haven't looked this up yet. But there was something called the Stethoscope Society. back in the 1800s when the stethoscope was invented. And apparently there was a lot of hype about which stethoscope to use, which way should we go, how should this be made? Similar to what we're seeing with how should we use these things, you know, when it comes to health. And so eventually, after years, I mean, I think it was a few decades before that was solidified and it was considered, you know, they had a model. But the basic idea was now it's just a tool, right? It's considered something you have to use. It's the norm. Well, we don't quite, you know, we quite haven't gotten there yet about which, you know, which direction, what works. And the point made in this chapter was when you get a program or a solution that falls into the mainstream, then you've, you know, it's no longer considered, you know, a tech gadget, but it's just part of the way things are supposed to happen.
So we just have a couple of minutes. I wanted to make sure if anybody had a question that was on their mind, this would be a great chance to do this from either of you, any of you. Deborah, any closing remarks you want to make? Or?
Well, you know, we talk a lot, I go to a lot of conferences. We talk a lot about the mHealth revolution and mobile technology and telehealth and all of the tech, you know, EHRs and EMRs and everything that's rolling out. But when I start getting too much involved in the hype, I come back to a slide deck that Rob Clodner, who was the national coordinator when I started at ONC, uses when he goes out to talk about technology adoption. He has a series of slides that show all of the articles in the Journal of the American Medical Association from 100 years ago about whether a doctor ought to use an automobile in his practice. So to your point, you know, as the technology, you know, we think that this is all new and exciting, and our grandchildren are going to look back on this and say, what was all the fuss about?
Right. Sure. That's fine.
All right, well, thank you so much, Deborah, Stanley, thank you. And you have a little break here before lunch. Thank you.